Thank you so much, Linda, Donna, Phil, Renata, and Martinez. It's such a thrill and a pleasure to be on this panel. And thank you for inviting me and having me here. As Linda mentioned earlier, I'm Dazon, and I work with an organization called SisterLove, which will be 22 years old in July. The masses go wild. And that in and of itself is an extremely important story to tell, simply because there weren't a lot of women on the front lines of this epidemic in the 80s while at the same time we were seeing white men being diagnosed in the cities of San Francisco and LA and in New York. There were also women being diagnosed in prisons and in substance abuse treatment facilities who also were living with AIDS at the time. And there were many, many women who were sick and dying, never receiving a diagnosis, simply because the conditions, the experiences that they were having, just because they were women, were not necessarily included in the treatment protocols, and so many died never being diagnosed. And to them we give honor and we give grace, simply because they shall never be forgotten and never not included in our new ancestry of those who have passed on. So if I could just do sort of like what we try to do in all our conferences, which is not to repeat but sort of fill in, because I swear it literally is the same, with the exception of a little bit more of a gendered lens. I want to point out a really important comment that Phil starts with all the time, which is that in America, yes, AIDS is a black disease. In the world, AIDS is a black woman's disease, and I want to be very, very clear about that. And that when you parallel the conditions and the experiences of women of African descent living in the United States with women in Africa and the African diaspora, we almost have a mirrored image, but for the sake of the economies of scale. Women occupy about 60+% of the epidemic in sub-Saharan Africa, which carries 2/3 of the epidemic in the world. And then you have an exact mirror of black women carrying about 2/3 of the epidemic among women in the United States. So there's very little parallel there. The other part very little distinction there. The other part of that parallel is that the largest experience of that is in the southern region of the United States, and the largest experience in the world is in the global south. So if you mix the social, cultural, economic, the geopolitical conditions that look similar in the South, because, I always remind folks that, yes, we've made progress, but we're in the region that lost the war. So wholesale, we're still a long way behind the rest of the country in terms of development, in terms of education, in terms of access to health, also in terms of politics and who gets what and who makes decisions about who gets what, and that we are always getting left behind, and oh, by the way. That's one of my insurance numbers. So if you just put those kinds of things in context, we sort of take a different approach to how we locate HIV in the social change work as well as in the saving lives work that we do. And the first and foremost of that, and I think that this is the story that rarely gets told, is the absolutely amazing human rights dimensions of HIV and AIDS. The human rights dimensions, which for me, if I just use the real basic framework of the human rights framework itself, means we have to consider the civil rights, the political rights, the economic rights, the social rights, the cultural rights, the sexual rights, the developmental rights, and the environmental rights of people who are living with HIV and or at risk or in the most vulnerable situations. And it doesn't take much to know that where we have the most disproportionate experience with HIV and AIDS is exactly where we have the most disproportionate experience of the violation of people's human rights, whether it's about access to care, access to housing, access to education, equal pay, gender and equity rights, the rights of sexual minorities, that all of these are critical, larger issues for which HIV brings a magnifying glass that we have yet to look at or to use that lens in a real way to mobilize our own communities. Another issue that I want to bring to the floor, which I think is also missing in the mix, is that not only is it a women's issue, but HIV is actually an issue of sexual reproductive health and rights. It's an issue that we define as an issue of reproductive justice. Reproductive justice working around 3 frames, right? Or a frame that includes 3 core components. One, that women have the right to have a child. That women have a right to have a child in the way that they decide, and in the where they want to have them, and in the methods of service delivery and care that they choose to do that. That women have the right not to have a child, to practice family planning and contraception, or to end the pregnancy should it come at a time when they are either not ready, not prepared, or not capable of managing that pregnancy or carrying that child to term. And then in the third instance, women have the right to parent the children that they have. Now, if you take any one of those frames and you apply HIV and the experience of women living with HIV, in each one of those sectors, I have dozens and dozens and dozens of stories where women either were denied the right to have the children that they wanted because they were discriminated against or treated in a stigmatizing way in their own private physician's offices or in the public health setting. That when it came to not having children when they chose to. In terms of women, for example, who are undocumented, we may have coverage because of our HIV care, but we don't have coverage for prenatal. We don't have coverage in terms of Medicare. We won't have coverage in terms of having access to family planning or to abortion services. And when it comes to parenting the children that we have numbers of women who are denied their parenthood simply because of the ignorance and stigma around HIV. If she ever had a substance abuse problem, if she ever had a problem with incarceration, if she ever had an issue where her parental rights were challenged, not only are they challenged on some of these other experiences, but I've got women who have literally been told, well, you're not going to be around to see them grow up anyway, why should we give them back? So when we look at HIV from a women's lens, it's not only about our issues around sexual risk reduction. It's not only our issue around understanding and assessing our risk and accepting our risk, because I think that's the other part of it. We have yet to accept that we're at risk in our communities. But it is a larger issue around our rights to self-determination and bodily integrity and autonomy around how we decide and determine the best course for ourselves in determining our families. And so when you hear an HIV positive woman stand up and say, well, you know, I like having sex too, most people have to shift their own paradigm to figure out how to support her in that. I'm serious about that. Or when she says, and she's 23 years old, she says, yes, I'm going to have a family. And there are people who said, but you've got AIDS. As if that is a precursor for her not having the right to choose that course for herself. So these are also other stories out there that are not being told. In terms of this 30 years later, I remind folks of this really cute story. And folks say, I don't know if it was my deciding moment yet. I got plenty of those. But my entree into this, get it, Rock Hudson. No joke. And I think it's befitting to mention that, especially in this week as we're honoring and memorializing Elizabeth Taylor. And what I mean by that is Rock Hudson came out with his AIDS diagnosis in July of 1985. Now, up until that point, there were AIDS service organizations, very small but still growing, that were almost solely, if not 100% focused on gay white men. No doubt, not even men of color, but gay white men who were living with AIDS. That's how we got that message, and that's how we've been stuck with that message for 30 years that we're still trying to turn around. But for some reason, when Rock Hudson announced his status, the phone started ringing off the hook from women. Now, I know we don't all think we are Rock Hudson, but we certainly might consider ourselves dreamingly as the leading ladies. Grace Kelly, Liz Taylor, you go down the line. I don't remember any black women, but for some reason, black women were calling as well, including women living with AIDS who finally got the message. Rock. It took rock. So I say that to say that there's another issue for us in our own community. And I'm just putting my dream out there, and anybody can pick this up and run with it. But in our own community, we need more than magic. We need more than magic. And what I mean by that is if you really take the numbers that Phil just ran down, if we really are greater than half of this epidemic, then you cannot tell me that since 1991, we have one black celebrity in all of America who is living with HIV and able to talk about it. And that obviously is something that we need in our own communities because we want to see someone at that level who we think we can identify with. And like I said, I don't know how we made the leap to Rock Hudson. But I know that my young folks today are not going to make that leap to Brad Pitt if he came out next week. Okay, y'all don't write that. I ain't saying nothing about Brad Pitt. I don't know nothing about Brad Pitt. That was just an example. It was an analogy. Clarify. So I bring all of these things up because when it comes back to focusing in on women, that we are definitely talking about a third of the epidemic, and we are trending right now, because that's how we work in this public system, is that we look at our numbers and that's where we put our resources. So we're trending right now to talk about men who have sex with men, gay and bisexual men, especially men of color. And what will happen is if there's not a squeaky wheel screaming the issues of women, then we will get left behind. And we have worked since 1990 and 93 to stay in the game. We have worked since we changed the epidemic definition back in 93 to make sure that women were included. And now we're back at work making sure that going forth in research, going forth in public health, going forth in the resources that are available through our sexual and reproductive health programs, that women are still included. I don't know anywhere else where 27 to 30% is not a significant number. Not a significant number. And so in this epidemic, it is also extremely a significant number in terms of the epidemic. And what do I mean by that? Is that, for example, with the PrEP, with the pre-exposure prophylaxis, we have a study, we have great data that's come out of that. It's specifically about men. There may or may not be a set of guidelines available right before the end of this year. And until we know what the studies around PrEP in women say, we won't have any guidelines around that, which means we won't have any funding around that, we won't have any continued research around that, and we won't have access to that. And what does that mean in terms of what we currently have with the strategy of treatment as prevention? We want to make sure that everybody who knows their HIV status is able to get access to care. We have changed the recommendations for it. We have lowered the CD4 count so that we make sure, we've raised the CD4 count to make sure that we are getting folks early and in longer. But we are also sitting right here in 2011 with over 7,000 people in this country who are on waiting lists to get support for those medications. Georgia and Florida alone carry more than half of those people on those lists because we don't have enough money to pay for the people who need medications now. And you're talking about providing support for people who are in behaviors that we don't support, that we want to make sure get access to care or access to preventive medicines. That's a conundrum I have yet for us to figure out. I know I've got to wind it down. I know that paper is coming my way, but Phil didn't yield. Phil didn't yield a lot of time, but what'd you say there?
It has a heart on it.
Oh, that's a hard on. Thank you.
One lovely minute.
So what I'll wrap up with is, and I think I've honed in on the sexual and reproductive health piece long enough, but to add to that, I'd have to bring this in. You mentioned the Heritage Foundation saying that black people are extinct, and what we will say about that. Well, they've already said it. As of this past year, the far right, the conservative movement against abortion as a choice, has decided to target the black community. In Atlanta, 80 billboards went up saying black children are an endangered species. A billboard went up in New York 3 weeks ago saying that the most dangerous place for an African American is in the womb. Now that's about abortion as far as they're concerned, but I can tell you in our support groups and in our groups of women living with HIV, that's a similar message that they have been getting for the last 30 years. And so there's an immediate connection between how the far right is soloing in on and zeroing in on our own protections of ourselves as a black people, our notions of genocide, our notions of oppression, and turning it around and making black women the culprits in all of this. So on one side, we're supporting, this is what I just wrote down, we're supporting protect penises, and at the same time, we're vilifying vaginas. That is the message that is coming forward right now, and we have a larger fight against our hands. So I want to take you to a couple of other things that I think are really critical in terms of forwarding this message. We've talked about human rights dimensions. We've talked about sexual and reproductive health. There are other trends that are coming along. We have women who are in their 20s who have been living with HIV since birth, and they have a story to tell. sexual debut, becoming an adult as a young black woman in this country living with HIV. We have women who are HIV positive who are leading movements, who are leading engaging activities, who are sitting in advocacy around research and around development of ongoing clinical modalities that help not only prevent but treat women better as they age and get older in life, since more people are living longer, taking meds for a longer time. We were talking about menopause and hormones and all of that kind of stuff, and how is that playing in. We know that while the National AIDS Strategy has adopted a larger focus, not on populations, but on conditions, we know that if we don't name it, it doesn't get attention. And so we do have to name the fact that black women and black men are definitely a part of this epidemic, whether they are having sex with the same gender or in the opposite sex. Closing is, we have a saying at SisterLove that we use really well, and we call it "Everyone Has a Story." And we've been working very hard to document those stories because that's a part of addressing stigma. The deciding moment is a part of addressing stigma. Telling stories, retelling stories, retweeting stories is a part of ending the stigma. So I invite you to our website, SisterLove.org, where we have just posted 5 vignettes of black Southern HIV-positive women who are talking about shame and stigma and disclosure and friends and networks and getting in treatment and staying on treatment and the issues that they go through, just as a message for other women living with HIV. And to continue this conversation, I invite you all to our conference in July with Sister Song Women of Color, which is the Let's Talk About Sex conference, the largest conference on women of color and sexual health issues in this country. We'll be in Miami. That should be attractive. In July of this year.